Hi, everyone. I'm Kevin Kunzman, Managing Editor of HCP Live. Obviously, I'm not at AAD 2020 right now. The meeting was canceled, as were most, if not all, of the upcoming major medical meetings that our team was planning on covering on ground, on the floor. So instead of that, we're going to do a special edition house call video interview with Dr. Linda Stein Gold, a principal investigator on a phase 2b trial that was assessing ARQ-151 in chronic plaque psoriasis patients. That presentation was going to be happening at AAD 2020, but instead we're going to be doing a video interview with Dr. Stein Gold right now about it. And here she is. Dr. Stein Gold, how are you doing today?
I'm doing well, thank you.
Thank you so much for joining us. I know it's just such strange circumstances we're working under, but I'm glad we can still kind of capture the spirit of discussion that would have been happening at AAD right now. But let's just get it exactly into the findings. This is a PDE4 inhibitor, right? So what exactly are the qualities of this drug, if we can start there, about the actual drug itself that shows promise in chronic plaque psoriasis?
Yeah, you're right. This is a PDE4 inhibitor, and this isn't the first time we've talked about PDE4 inhibitors for psoriasis. We do have an oral agent that's FDA approved for psoriasis, and we have a topical agent that's FDA approved for atopic dermatitis. And this particular drug is actually already FDA approved in the oral form for COPD or chronic obstructive pulmonary disease. So it's a molecule that we've come to understand. This is a drug that we've deemed safe in the oral formulation, and now we're studying it topically for plaque psoriasis.
Okay, excellent, great. And what exactly was the patient population that we're assessing in this phase 2 trial?
So what we were looking at is adults. So everybody had to be age 18 or over. And we looked at those patients who had plaque psoriasis, which the majority of our psoriasis patients have. That's just the large plaques on the body. And we allowed patients who had mild, moderate, or severe disease to enter into the study. And this was actually a dose ranging study. We actually looked at 2 different doses, looking to see which one was more effective. And we also looked at it as compared to the vehicle itself.
Okay, excellent. And anything particular within terms of duration of the trial, dosing? You said it's a dose-ranging trial. So what exactly were the particularities of that?
Yeah, so we started with 331 plaque psoriasis patients. They had anywhere between 2 and 20% body surface area involved. And we looked at 2 different doses. We looked at a higher dose, which was 0.3%, a lower dose, 0.15%, and then the vehicle. And everybody used the drug once a day for 12 weeks. Our endpoint, or our primary endpoint, was actually at the end of 6 weeks. And we're looking to see how many patients got to clear or almost clear. And that can be a little bit confusing, you know, when you say, okay, what does clear or almost clear mean? It means when we look at the patient as a whole and we stand kind of at arm's length, we look to see how many of them were completely clear of their psoriasis or just had some very, very minimal residual disease, like just a little bit of pink skin or a little touch of scaling, but overall got to a completely clear, almost clear at the 6-week time period. So that was the primary endpoint, although we did follow patients throughout the 12 weeks. Another interesting aspect of the study is we also looked of those patients who came into the study who also had psoriasis in skin folds or intertriginous areas. And we evaluated those areas separately because those can be difficult areas to treat. Those are areas where we don't use potent topical steroids, and it's nice to have another option.
It seems like a lot of the promise that we see of the inhibitor classes that are being assessed right now for some of these dermatologic conditions, the inflammatory-based ones, is in its overall improvement for patient quality of life, even if that's not the direct effect that we're assessing. Like you said, skin clearance, PASI, things of that nature are almost always the priority. We do see a ton of secondhand benefits. Can you talk a little bit about, I guess, like case by case of how patients are responding to it overall beyond even just skin clearance with this investigative drug?
Yeah, one of the other things we looked at was some of the quality of life indicators and also itching. You have to remember that a lot of patients feel that itching is one of the most bothersome features of their psoriasis. And we know that we saw a nice improvement in both itching and also their psoriasis symptoms diary, which kind of captured some of those troublesome aspects of the psoriasis on patients' quality of life. So it was nice to see that patients were starting to see an improvement as early as week 2 in some of those measurements.
Wow, week 2. That's remarkable. That's exactly what you're looking for, right?
It is, and also, when we look at the primary endpoint, we found that both of the active drugs were statistically better than the vehicle in getting those patients to almost clear. And so that was true at week 6, and we saw an improvement at the other time points as well.
That's excellent. And how exactly do these findings, I guess, feed into the next round of assessment? What exactly is going to look to be done with this now?
When you do a successful trial in the phase 2s, often we use that data to guide us to go forward. So the first question we have is, does the drug work? And in this case, yes, it did work and it met its endpoint or endpoints. And then we say, okay, well, which concentration do we think we should go forward with? And in this case, the higher concentration, the 0.3%, was more efficacious. It was deemed to be safe. Most of the side effects for the active arms were mild or moderate. So that will be the one that we'll go forward with, is the higher one. And we are looking at phase 3 clinical trials going forward even now.
So particularly when we're speaking about these inhibitor drug classes that are showing such great benefit and efficacy, especially early on in patients, something that's sort of disclaimed by physicians is that these are therapies for later stage patients that are dealing with more severe symptoms and are just at a greater need for it. And as such, it's a little bit more limited in its use in the field. Is that something that's similar for ARQ-151?
Well, actually, when we look at the patients who entered into this study and who did well, we know that these are patients who had either mild, moderate, or severe in terms of the quality of the plaques themselves, the investigator's global assessment at baseline. And we also know that these patients had disease that went anywhere from 2% all the way up to 20%. So some of those patients did have more extensive disease, but the majority of them had more localized disease. So this is a drug that's probably very appropriate for our typical psoriasis patients.
That's excellent to hear. And obviously the patient population is pretty significant, relevant to other conditions that we're treating in this field. What exactly does it look like, I guess, in comparison to other agents already in the field if this were to become a competitor on the market?
So that's often difficult to say, because the best way to know how a drug compares is to do an actual study where we do a head-to-head comparison.
Right.
So that's difficult, but from the preliminary data, it does look like this is a drug that probably could compare to a potent topical steroid. So it looks like, and the truth will come out in the phase 3 when we have a larger patient population. But it does look like this drug does work fairly well. And it looks like it's a drug that could potentially be used as a monotherapy. And the good news is, when we look at the way it worked in the sensitive areas, in the skin folds, it actually did quite well. So what I like is when I have a drug that I can use on multiple body surface areas, that's safe for different areas, that's effective for different areas, it makes it a lot easier on the patient.
That's great to hear. That shows great promise, I think, for the patients. It's great to hear that more options are coming. If we could just switch gears a little bit, back to obviously AAD not being held this year, that it kind of puts a damper on everything, but at least we do have the capability and option to, again, discuss some of these bigger findings that we're going to headline the meeting. Could you maybe fill us in on maybe some of the other topics that you're hoping to at least sit in on or get to discuss with your colleagues? What are some of the biggest topics in derm right now that you're looking forward to at AAD 20?
Well, I agree. It was really unfortunate that the AAD was canceled this year, but it was necessary. And now where we see where this country is, right on the eve of when we would have had the AAD, we know that there was really no option in it. We couldn't continue to hold the meeting. But there is a lot going on in research right now. And one of the key areas is not only psoriasis, but also atopic dermatitis. So I know that there are just a whole whole category of new drugs that are being studied. We have the JAK inhibitors, both orally and topically. We have new biologic drugs. So this is a really very, very exciting area. We have some new acne drugs that have been approved and some others that are awaiting approval. So I think it's just an exciting time. Hidradenitis suppurativa, there is some additional work being done with other biologic agents. So the AAD is really just a premier meeting. It's important that we all stay safe. Hopefully we'll see everybody in the summer for the summer AAD, and we'll get some of this additional information out then as well.
Yeah, I think that's a optimistic point to end on. But is there anything else you want to add, Dr. Stein Gold, within regard to this finding, AAD, or anything else really going on right now in the field?
Well, I want to say that I think it's still really important that we pursue topical therapy. This is a drug that's a class that we understand. This drug happens to be many, many times more potent than the currently available phosphodiesterase type 4 inhibitors. So that's kind of exciting. And when we look at our psoriasis patients, I know we have a lot of really exciting biologic drugs, but as you mentioned earlier, those are really appropriate only for a smaller population of our more severe patients. When we look at the overview of who our psoriasis patients are, most of them have localized disease, and this drug would be appropriate for them.